Thank you. Thank you very much. Well, good afternoon and welcome to all of you joining us today. I'm Scilla Springer, EXCO member of SA Child, and I'm joined today by my co-hosts, Dr. Heather Thompson. Do you want to put on your video, Heather? Dr. Gillian Salugi and Dr. Dina Simmons. Southern Africa, SA Child is a Southern African representative of the International Alliance of Academies of Childhood Disability. Our purpose is to improve the health and well-being of children, adolescents, and adults with childhood onset disability. Therefore, our organization is diverse and multidisciplinary, and we welcome all those who share our aims. And that means that families, people living with childhood onset disability, medical and allied health professionals, educators, social workers, researchers, and policymakers are all welcome to join our organization. We're especially keen to increase our membership of other SADC countries. And please, we will chat our website in the chat box. We will post it in the chat box, and it links to the membership form. So please, if those of you have contacts, send them to any SADC colleagues. Today's webinar is part of a 24-hour virtual event organized by the IAACD, and we thank them for allowing us to join. The theme is diagnosis versus functional thinking and best of both worlds. As this will be the SA Child's first webinar on autism this year, we thought that the theme particularly pertinent. Before introducing the speaker, a few housekeeping rules. Please adhere to Zoom etiquette, switch off your microphones and videos, mute yourselves while the speaker is talking, but you're welcome to post questions and any comments in the chat box, and we will have a discussion afterwards. Also, as you can see from the slide, this is being recorded, so if you wish to remain anonymous, switch off your video and don't post in the chat box. So without further ado, I'd like to welcome Professor Beatrice de Vries, Professor of Child and Adolescent Psychiatry and Director of the Center for Autism Research in Africa from the University of Cape Town. Beatrice is the current president of the South African Association of Child and Adolescent Psychiatry and Allied Professions. He did his undergraduate training at Stellenbosch University, and before moving to the UK, where he did clinical training in child and adolescent psychiatry, and also a PhD in developmental neuroscience at Cambridge University. He returned to South Africa in 2012 with considerable clinical and research expertise. And since then, he has focused on global child and adolescent mental health and on the implementation of science in low and middle income settings. Apart from autism, Beatrice has a clinical research program in tuberous sclerosis complex and its associated neuropsychiatric disorders. And through his representation on local and international organizations, he shifted the focus of autism research from high-income countries to low-middle-income settings, especially Africa. As he says, after all, the highest proportion of children with autism live in low- and middle-income countries. He is very much in touch with challenges faced by parents, both in getting an assessment and a diagnosis for their child, and he has advocated for improved access and provision of services for children with autism. Welcome, Beatrice. We are looking forward to your talk and the discussion afterwards, and I'll hand over to you.
Lovely. Thank you, Stella. I think you said such lovely things about me. We should just conclude the whole session there, because I'm not sure I'm going to sound quite as nice as you made me described me today. But let me share my screen and just make sure everyone can see. So if you just give me a sign that everybody can see my screen, Scylla. That looks fine. Great. So in that case, thank you very much. And I love this idea of a 24-hour around the world session on neurodevelopmental disability. And I earlier spoke to Johannes, who's obviously attended many of them around the world. So welcome to the African version of the Around the World tour. I thought it was a great idea. Diagnosis versus functional thinking, best of both worlds, that you have or had as International Academy. And when Scylla and I then spoke about what she wanted me to talk about or what might be relevant for people, I thought, well, we thought long and hard, and we came up in the end with this topic called Towards Holistic Assessment of the Child with Autism. I'll come back to the topic in a minute. Let me just check. I can hear papers rustling. So I wonder if maybe SA Child team, maybe you want to just check who's not muted, including yourself, I think. I think the SA Child line might not be muted. And before we continue. If anyone hears rustling of paper, just let us know. So, having said that, before I continue into my presentation, I think it's important for me at least to greet you all properly. So greetings from the University of Cape Town. Here in Cape Town, here you can see beautiful Table Mount. And for those who don't know South Africa and the city, here you can see the University of Cape Town, the buildings against the mountain. And right here in the front is actually the Division of Child and Adolescent Psychiatry. And this is where our clinical activity and our research is based. And greetings also from my research team. You heard Scylla do a brief introduction to the team called the Center for Autism Research in Africa. Here's some of the team members. You can tell, if you're well observed, you can see this is in the time of COVID, but we're sufficiently post-COVID and we're sufficiently vaccinated that we could have a team photograph outside under the trees. But welcome and greetings from the team. We're a very interdisciplinary, highly transdisciplinary team, interested in many aspects of autism and autism research, screening and diagnosis, intervention research, educational and health systems research, training, technology, and so on. But all of it very much through the eyes of the cultural, the socioeconomic, and the linguistic diversity of the populations that we serve. And you can see here from our little logo, our logo is very much an African tree, and we want the tree to have fruits and connections and links throughout the African continent, and in fact, throughout the world. So if any of you are interested in discussing, having conversations with me after today, please do feel free to get in touch. So let me now go to the topic and the theme that Scylla and I thought in the context of your overall conference might be useful, towards a holistic assessment of the child with autism. So a number of keywords that we will just dissect for a minute. The first, assessment. So I will focus on assessment or workup or evaluation rather than to focus primarily on intervention, but I hope there's a minute at the end just to say something about intervention, because doing an assessment without intervention in mind doesn't make a lot of sense. Second keyword, the child. Even though the emphasis or the interest in this group might be on children, I think what I'm going to say is not going to be child specific. So hopefully it'll be relevant across the age range and across the developmental spectrum. And third, the keyword, the word autism. Yes, I'm talking specifically using autism as an example of a neurodevelopmental disability today. But once again, I hope that many of the principles we will talk about will be relevant. So autism in a way is an example or a prototype for neurodevelopmental disability rather than that it's only about autism. And then finally, the biggest keyword, the word holistic. And I don't know how many of you know that the term holism was actually coined by a South African, and by this man in the photograph, who is Jan Smuts. Jan Smuts is a very well-known, very famous statesman. He was a general, but he was also the prime minister of the country on 2 occasions. And many people know about that part of his story, but he was also an incredible intellectual and academic. He studied at Cambridge, worked in Cambridge for some time, and while he was in Cambridge, actually wrote this book called Holism and Evolution. He wrote it in 1926. Apparently, this was a topic of interest at the time. And Smuts's idea, Smuts's concept of holism, he described it as a fundamental factor operative towards the creation of wholes in the universe. Or another phrase from his work is a process-oriented hierarchical view of nature. So to make it simple for us and for this conversation today, Smuts's view and description of holism was that all the components, subcomponents in the universe, in the world, gradually assemble in natural ways towards wholes and greater wholes. And that's, in essence, the idea of holism. In contrast, scientific contrast to that is the construct of reductionism. So in reductionism, one would start with a whole and you would try to break it down into the most fundamental or essential component part. So you can see that holism and reductionism perhaps had a kind of an opposite end of the spectrum perspective, at least in the way that Smuts wrote about holism. So for the purposes of today's talk, this is what I'm going to do. I'm going to start with the child in context. And then from that, I will divide it into meaningful components. So in a way, the first goal of my talk is really just to generate an understanding of the child's need across many different levels in context. And ultimately, the purpose of that is so that we can inform intervention and support. So here, the picture at the bottom is perhaps what I'm going to do. I'm slightly cheating, starting with a whole, then dividing it into components, and then coming back from those component parts to try and see how do we then come up with a holistic understanding of the child. So 3 parts to my talk. The first I will talk about is the child with autism in context. Then I will move on to different levels of investigation. Maybe in a way that will be the meat of the presentation. And then I'll come back to how, therefore, do I do, or can we do, a holistic assessment for autism. Here's your beautiful picture again, diagnosis versus functional thinking, best of both worlds. I'm going to try to persuade you that even though this is a fun idea and a good idea, the argument I'm going to make is that diagnosis versus functional thinking is in fact a false dichotomy. We need diagnosis and functional thinking. And in fact, there are many other levels and layers of thinking that I believe we need in order to have a holistic understanding of children with autism. So when we get to the end, you can see if you agree with me about my prediction. So let's start and begin with the child with autism in context. And I'm going to zoom out as far as I can zoom out before zooming back in. And here's as far out as I can zoom at the moment. And that is to say, we think about a child with autism in the context of neurodiversity. You will all know that it's a construct and a concept that we all now accept, that all of us are somehow and somewhere on a neurodiverse continuum. We all have strengths and weaknesses. We all bring strengths and weaknesses to everything that we do and how we interact with the world. And all of us may have a range of different strengths and weaknesses, not just our patients or the people that we support and work with. But within neurodiversity, we also accept that there may be a time and there may be some people who, because of their neuroprofile, they might become distressed, they might have impairment, they might struggle to function in the world that they live in. And therefore, they may come to clinicians and physicians and a range of professionals to seek support. The second big picture consideration for us in context is that of global diversity. And Scilla has already commented on that. Here I am sitting at the southern tip of Africa, but the world we have many universal things, but we also have lots of differences, cultural, linguistic, and other differences. And as Scilla said, we know that most children with autism live in low and middle income countries. Only about 5% of the world's children live in rich countries. And yet almost everything we know about autism, the way we think about autism, is very much constructed through the eyes of high income, rich, what some people call westernized countries. And so there's a gap. So for us to think about a child in context, we have to think, what is this child with autism in a global diversity, such as my own? The next level that we have to think about a child in context is that of the heterogeneity and the uniqueness of this child's autism profile. This is my little, it looks like a bit of a, I don't know, a windmill or a flag or something, just to show, I use this with students, 2 main domains of autism, 3 subdomains on the one side, 4 on the other. And for us to say somebody has autism, we need to have evidence of challenges, difficulties across both those domains. And you will also know, as people who work in neurodevelopmental disability, that if we start to tease apart all the possible socio-emotional reciprocal problems, the non-verbal communicative challenges, the developing, maintaining, and understanding relationships, plus all the restricted and repetitive items, the number of combinations of the kinds of challenges that a child with autism may have is vast. There's an almost infinite variety of possible presentations of a child with autism. And we need to think, how do we hold that in mind as we try to do a holistic assessment? And once we've now got our heads around the diversity, the heterogeneity of autism itself, now we're going to see and think also of all the other possible behavioral challenges that a child with autism might have, all the additional neurodevelopmental disorders they might have, or other mental health conditions they may have, of all the physical health challenges we might see. And all of that will help us think about this child and how that might play out in their current functioning and also in their later functioning in adulthood, in jobs, and so on. And then, once we understand this child's autism, their neurodevelopmental profile, their mental health and physical health profile, now we also need to think that this child might live in the context of caregiver mental and physical health problems, of single-parent, chaotic, challenged families, of poverty, of lack of access to support. And we all live in different contexts with different health education, social care, and other sectors. So we also need to think, well, what are the systems available that might be needed to support this child with autism and all the other factors that we think about? So I hope by now you all agree with me that an assessment that leads to a simple yes/no diagnosis of autism is virtually meaningless, given that we think about a child in context. And therefore what we need is a formulation of the needs of this child. And so this is maybe a good time then to switch to the kind of second part of my thinking and of my talk. And that is how we think about different levels of investigation. Any of us, all of us, when a child comes into the clinic, when we meet people, whether it is for clinical, for research, for any other kind of purposes, we will think about the child with many different possible models. And I'm just going to show you some of these very typical models. So we see a child in clinic, and we might look at the behaviors that they present to us, whether they're inattentive or impulsive or depressed or dysregulated. They might have language problems. They might have social difficulties. These are all the behavioral things. We're going to think, what are the behaviors that are bothering people? We might think about the child in a psychiatric model. So we might think, do they meet criteria for disorders? That's one level and one way to think about this child. Another way we might think about the child is to think about their school performance, their academic achievements, how they do, what might be challenges in that model of thinking. some of us might also think about the global intellectual abilities of the child. So how are they in relation to others, and does that help us understand some of the behaviors we observe? Hopefully, many of us will also think about the biological model. Might there be some physical illness or seizures or other kind of syndromal things that might help us understand this child? And of course, particularly for us in psychiatric or child mental health settings, we also spend a lot of time thinking about the psychosocial profile and the psychosocial needs, impact of relationships, parenting style, divorce, poverty, parental mental illness, all those kinds of things. And apart from all these models, they're all different ways, one could think about them almost as different lenses through which you can look at a child who presents to a clinic. There's another level that I deliberately wanted to add today, and that is the neuropsychological or brain referenced level. And the reason for that is because most of us don't really think about this level of investigation. And I'm going to spend a few extra minutes just talking about the neuropsychological level today. The challenge we all have, and the problem you will have and we have as we're having conversations, and that we've seen in the autism community, in the tuberous sclerosis community, in all of disability, is people in different professions, in different cities, in different countries use different language to talk about these things. Here on the screen, you can see a lot of different words that I'm sure you all use and we've all used. Cognitive, behavior, neurocognition, neurobehavioral, neuropsychological, mental health, neurodevelopmental, learning. Hopefully nobody uses this word, mental retardation, anymore. It's an old-fashioned word that nobody should ever use. But the point I want to make is that these are terms different people use. And sometimes you and I might use the same term, but actually mean different things. Or sometimes we might use different terms and actually try to refer to the same concept. That makes it confusing for us to talk to one another. And it makes it confusing for families that we're trying to support. And it also makes it really problematic when we're trying to do research about these things, if we're not clear exactly what level, what constructs are we talking about. And before I continue, S.A. Child, I think you are still unmuted. So if you are there, if I could, maybe you need to stay unmuted for the recording, I'm not sure, but just to point out, I can still hear. So from those funny terms, here's an example that we experienced in the tuberous sclerosis community. I'm sure many of you have seen or worked with people who have TSC, a rare disease, where we see lots and lots of different neuropsychiatric and neurodevelopmental challenges. And we discovered that so many people were concerned about many of these challenges that children and adolescents and adults have in TSC, but they were all using different language. And so what we did in the TSC community is we actually coined a term called TAND, or TSC-associated neuropsychiatric disorders. And we described and defined the various different levels of investigation so that we could have standardized terminology in the TSC community. And what I'm going to do now, if any of you are interested, there are some papers about it, where you can look at the TAND Consortium website. All these are open access and freely downloadable papers. What I'm going to do now is I'm going to walk you through the levels that we've described, what we mean by each of them, and give some examples of the typical challenges that we see in children who might have autism. So I'll start with the behavioral level, the psychiatric, the intellectual, the academic, the neuropsychological, the psychosocial, and then I'll say something about the biological level as well. So even though we made up the umbrella for TSC, the umbrella is really universal in how it tries to structure and define different levels of thinking and different levels of investigation. So let's start. The first level, very simple level, is that of the behavior level. This is simply the level where we observe whatever it is a mum and a dad and a granny and a child brings into the clinic. We might do direct observations. Sometimes we use surveys, rating scales, checklists, all those are simply ways to describe behaviors. Please remember, a rating scale does not diagnose. So these are purely ways to describe behaviors and summarize behavior. And as you know, in autism, we see very high rates of many behavioral challenges: aggression, self-injury, attentional problems, social communication. Of course, that's part and parcel of autism itself. Mood, sleep, many different behaviors. And we need to think, what are they and what are the priorities that we need to think about? Some of these behaviors correlate with intellectual ability, some of them don't. Some correlate with seizures, seizure disorders, some of them don't. So the key for us is we need to look for and describe carefully all the challenges at the behavioral level. We don't interpret and say this is a behavioral, so that's a risk I think we're all may commit. It's purely to describe. The next level we're going to move to is the psychiatric level. Now we're going to think of all those behaviors that we've observed and use diagnostic systems like ICD or DSM. And there are some standardized tools people could use, but even just a diagnostic workup using clear diagnostic criteria is a psychiatric level activity. And we're going to therefore say, are there enough behaviors for long enough to the exclusion of other things, not better explained by other things, of certain severities and intensities to meet criteria for whether it is autism or something else. And we know in autism, the moment a child has a diagnosis of autism, they are at significantly increased risk of other neurodevelopmental disorders like ADHD, like intellectual disability, language disorders, and others. And when they have a diagnosis of autism, they're also at a much increased risk of other mental health disorders like anxiety disorders, depressive disorders, OCD, sleep disorders, and so on. And so that's the activity at the psychiatric level we're going to make. The next level we're going to move to is now in a separate way, we're going to think, what is the intellectual level of this child? And this is using IQ type measures, adaptive behavior measures. So how do they perform under standardized conditions, but also how do they function in daily life? And as you all know, we place children on a normal distribution and we try to see, does it give us a sense of the profile? There are many different tools. They come with challenges because we know that these IQ type measures are very strongly correlated to educational quality. And in many countries of the world, including in South Africa, many African countries, most low-middle income countries, there are significant challenges still with quality of education. And so we need to think about IQ type measures with caution. But, and I will come back to that, we are not just going to see where does a child fall. Nowadays, we know that the majority of children with autism will have normal intellectual ability. That might not be the case still in Africa or many low and middle income countries because we still don't identify the majority of children with autism. But across the globe in international data, the majority of people nowadays with autism have normal intellectual ability. But, and I will come back to that, they very often have uneven profiles. I will talk more about that in a minute. Our next level down is the academic level. This is where we're going to think about the educational environment, how children do in the academic, scholastic skills. There's a number of different tools that people can use for that. And at this level, we may diagnose learning disorders. That's the correct DSM term for having a specific disorder of reading, of writing, of spelling, and of mathematics. And we know in autism, any and all of those are possible, not just associated with the overall intellectual level, but there might be a very specific disorder of these aspects of learning. And now we come to the neuropsychological level that I said I wanted to spend a few extra minutes just thinking about with you. And this is when we're going to do a functional assessment of brain skills. And there are many, many different sort of tools in the world that people can use and have used, that you might use or have used. And many of you might have a good understanding or might use neuropsychological skills and strategies and approaches. But for those who don't, I thought it's just useful to talk a little bit about this in more detail. So how neuropsychology tries to understand the brain is we start off saying, we know from neuroscience research that over time, the infant and the young brain gradually become specialized in different parts of the brain to perform certain kinds of tasks and certain functions. And therefore, by knowing which different components of learning and memory and other skills happen where and when we expect them to happen, we can use that as a way to measure the strengths and the weaknesses of an individual child or adolescent or adult or ourselves, in fact. And then we use that neuropsychological profile to explain current behaviors. Do you remember that behavioral level? And to try and predict future behaviors. So if you imagine, this is my brain, my head from above, we divide it very simply, and I'm oversimplifying here, into a number of different axes. So we're going to say left, right axis, front, back axis, and inside, outside axis. And very simplistically, the left hemisphere typically becomes specialized in language-based functioning. The right hemisphere typically in spatial and visuospatial and more attentional processes. The back of the brain is much more comprehension, taking in processing systems, whereas the frontal brain structures are what some people might call management systems or production, output systems. That kind of explains why we all might have this tip of the tongue phenomenon. You know something, it's somewhere in your brain, you just can't get it out. It's like the comprehension posterior bits are there, but the anterior producing it bits aren't quite there. And then when we think inside, outside, inside subcortically, we have much more regulatory functions of the brain. And on the surface of the cortex, we have more higher level processes. Now, of course, as I said, this is a huge simplification, oversimplification. We don't just cut our brains in lines like that. So we're really thinking about networks, frontal networks, posterior networks, anterior posterior networks, and so on. And in a neuropsychological profile, the job we try to do, or the question we're trying to answer, is this. We ask the question, is this child's brain skills proportionate or disproportionate? And so a useful way maybe to think about it is if you imagine these are like little matchsticks or sticks of my brain skills. So if these are all the different neuropsychological components of my brain skills, you can see they're all pretty similar in length. So maybe I can sort of average it out and say my average brain skills are sort of here. But the key thing is, and this may be the pattern for many typically developing children, however, for most children who have a neurodevelopmental or mental health disorder, they tend not to have proportionate neuropsychological profiles. And they may look like one of these two examples. So for instance, there may be many children who might have good skills, normal skills, even strengths in some of their brain skills, but they might have one or two areas of very specific particular weakness. And unless we look carefully for those, we might not spot them. And if we just average things out, we are also probably going to miss those gaps. And so we may see a child who has incredibly high intellectual ability, but might have very specific areas of weaknesses. The second example is even more common in children who have autism and developmental disabilities. And that is, we might see a child who has some real skills, even sometimes amazing skills in some functions, and some average skills in others, and then some particular gaps in others. And so you can see there's absolutely no point in averaging out and giving a mean score for this child's strengths and weaknesses. This is a model that applies to all of us. So I think it's quite a functional and quite a strengths-based and skills-based approach. And of all the different brain skills that we may measure, the most common difficulties that we see in children and adolescents, and adults, in fact, with developmental and psychiatric disorders are in these anterior, these production systems. And you will all have heard of executive control processes, executive skills, executive functions, whatever the word is you might call them. Those are the most commonly affected domains. Now, I again, many of you might be very comfortable and familiar with executive skills. Perhaps some of you are not. I've spent a lot of time trying to think how to explain this to families and to mums and dads. And here's my analogy. So this is a picture of a much younger Professor de Vries. And here, and here in the back, you can see Olivia. What you can't see is I was starting to drive away. And there was a little narrow road, a little bridge in front of me. And on the one hand of the bridge, there were cows. And on the other hand, there was a steep cliff down to the sea. And so as I was driving away, I had to check that she wasn't climbing out of the window. I had to know where I wanted to go. I had to watch out for the cows and stop if I saw one. I had to make sure I didn't go too far left or too far right. And I had to do all of those things at exactly the same time. And in a way, that's my analogy for the executive skills of the brain. The executive skills are like the driver of a car. It has to be alert and awake all the time. You have to stop and start at the right time. You have to keep an eye on the road and be vigilant. You have to know where you want to go and how to get there. And you have to do all those things all at the same time. So that's in principle what executive skills are about. And this is just exactly the same, perhaps just in slightly more technical language. You talk to different executive skill experts. Ooh, Rachel de Vries, I think I can hear you doing something in the microwave. So maybe just mute yourself. We have three main domains: regulatory mechanisms, and they include, well, let me tell you first, regulatory, attentional control, and goal-directed mechanisms. And so here, under the regulatory mechanisms, we think about the arousal, the alertness levels of a child. We can think about, can they inhibit automatic responses? When we think about attentional control, we're going to think, how good is this child at focusing their attention? How good are they at sustaining attention? How good are they at switching, at dividing their attention, or at doing two things at exactly the same time? These are all related but different brain skills. Okay. The next are the goal-directed mechanisms. And these are some of the ones that you might be more familiar with. Planning a task, sequencing or organizing, tracking, working memory that's holding a small bit of information in mind as you're doing things, cognitive flexibility, so that's the ability to change a plan quickly if you need to. Perspective taking is being able to have insight into others' thoughts. Metacognition is being able to see that for your own, having insight into your own mind and thoughts. So that was a short whistle-stop tour about skills, but this is why they are important. When executive skills have difficulties, it may manifest in daily life in many different ways. Learning, focusing in the class, getting in trouble, academic difficulties can present. Children might be stubborn and willful and deliberate, and people say, oh, he's just a difficult or a naughty child. They might appear anxious or withdrawn because they have a sense of things not working quite right. They might have very inconsistent and variable behavior. It's almost characteristic of executive deficits that one day a child might do well in the class and tomorrow it's as though they never learned those things in the first place. That variability is characteristic. And then, of course, the thing that's most likely to bring children to your and my clinic are dysregulated behaviors like irritability, aggression, tantrums, self-injury, property damage. And all of those may be consequences of deficits in executive skills. So, to come back to the neuropsychological level, in autism, the majority of children with autism, of people with autism, will have some neuropsychological deficits, including those who might have completely normal intellectual ability. I had a child in the clinic who had an incredibly high IQ, but he had very specific deficits in his cognitive flexibility. And that was the thing that prevented him from being able to access education and made him anxious and made him avoid all sorts of learning tasks. But children can have problems in memory skills, in executive skills, in attentional skills, even in visio-constructional skills, even though we think autism is a very visual domain. It's just not always the case. The psychosocial level is the second last one on our list. this is where we're going to think, what is the self-esteem of this child, the psychological impact of the disorder? How do they feel about their sense of being able to be and act in the world? What's the impact on the family? Autism is the neurodevelopmental disability that has probably the greatest impact on parental stress of all disabilities. Are there resilience factors? But a very important one also is their family mental illness, because we know the moment that there's family mental illness, the likelihood of a child having it impacting the child, either whether it be at a psychosocial or at a biological level, is incredibly high. So a family mental illness is a very significant risk factor for a child of also having a mental illness. And then the biological level. Hopefully many of you, particularly the medics, will be quite comfortable with this level, where we're going to think about epilepsy. Might this child with autism have epilepsy? We know the rates of seizures and seizure disorders are significantly higher in autism. Might there be a syndrome like tuberous sclerosis that we talked about, Fragile X, NF? There's a whole range of possible syndromes. Are there gastrointestinal disorders? Are there medications, not just that will treat things, but that might actually cause some of those behavioral or other kinds of challenges that we may experience? And so I hope by having talked you through and explained the definition and the kinds of things we look for across all these different levels, you will see how it might be important and different to think about a child with autism across these various possible levels. And so if I now go to think about a holistic assessment of the child with autism, this is the image that I have in my mind as I do clinical work, as I supervise junior doctors, as I think about my research questions. I start by saying, what is the profile of need at the behavioral level? What are the things that worry people? What are the symptoms we need to focus on? What are their priorities? Then I think, how many of those and what do actually translate to a psychiatric diagnosis? It's very confusing for families and for our educational colleagues to think that a child might have behavioral difficulties without having a disorder. You can be anxious without having an anxiety disorder. You can have social communication problems without having autism. You can have attentional difficulties without having ADHD. So this is because of the differences between these two levels of explanation. But it's important that we think, do they or don't they meet criteria? Because we know that that's going to guide our next steps. It's important to think about the intellectual level. I know we work in low resource context. Most of us, we don't have access to high level investigations across each of these, but at least we can think about it, ask the question and say, are there evaluations? Has it been thought about? Where is this child in their overall intellectual skills? We should think about, how are they doing in school? Are there particular academic difficulties, regardless of all the other levels? And it's really helpful, as I've tried to point out to you, that the neuropsychological level, just thinking in a brain-referenced way. Remember, IQ tests are actually completely not brain-referenced. Maybe some components are, but on the whole, that's not how they were designed. But neuropsychological skills are really trying to tap into different strengths and weaknesses in a brain. The psychosocial level is absolutely fundamental. I know that very often people who work in pediatrics, pediatric neurology, developmentalists, are a little bit scared about the psychosocial level. But this is the level where we really need to understand the burden on families and how we can help think with families about the quality of life, not just of the child, but of the whole system. And of course, the biological level is important because it may give us particular clues to things that we can or should do, or even clues to things that we should avoid doing because they might actually make things worse. So I hope that you are starting to think with me that if we really think about all those levels, I literally draw them out on a piece of paper as I try to think about a child's needs, that if we do that, we will have a sense of this child's heterogeneity and their uniqueness in terms of their autism profile. And if we have a sense of their autism profile, then we will also have a sense of which of these behavioral challenges we might need to think about and whether any of them or some of them actually meet criteria for disorders like ADHD, like intellectual disability or language disorder, or like some of the other psychiatric disorders, sleep, anxiety, depressive, OCD, and so on. And it'll help us think, are there also physical conditions and physical considerations that we might need to think about? And hopefully, that if we think about all the 7 levels, we will also have an understanding of the caregiver and the family health and the context of poverty, if they have access or no access to resources, what the system is that families live in that we might need to try and target. We all know that we live and work in problematic systems and services. And so it's about thinking, how best do we target what we do? And if we do that, then hopefully we can place our intervention in the context of the cultural, the linguistic, the traditions of the people that we're serving. And ultimately, we can think how this relates to a child who might be neurodiverse in a global context. So I'm going to end, and I can see Scylla here. That means I asked her to come online when my 40 minutes are up. I'm going to take 1 minute just to say something about interventions, because it's in a way pointless to think holistically about assessment if we don't think holistically about intervention. And here are my 10 points, and I will just say 5 seconds about each. The first one, hopefully now, will make sense to you. We need a holistic assessment to guide holistic intervention. We can't do it without that. There will be no single intervention that will work for everybody. So we need to find the right combination for this child. We need to accommodate, we need to work around the challenges, but we also need to build skills through the core difficulties of autism. And the short answer is we have tools and interventions that can do that now. We have to look for and also treat those co-occurring conditions that I've shown you, because they can sometimes have just as much of an impact or a greater impact on the child. We have to be focused on the family. A child lives in the context of a family and of a community, and all the work we do should be in partnership with them. We then need to use early interventions in early years and identify all those problems as they come on over time. Understanding the meaning of behaviors is a whole other talk that we'll come on to. Then we need to make sure we try to be evidence-based, evidence-informed in whatever we choose. And ultimately, we need to make sure, given that we all work in low and middle-income countries, we'll never have enough therapists or experts to work with every child. So we need to empower families with knowledge and skills, and we need to use the current contemporary evidence-informed approach for intervention in autism, which are the naturalistic developmental behavioral interventions, or NDBI. I hope we might have time to talk more about those in the discussion. So I'm at the end of my talk. I hope I've persuaded you that it's not just about diagnosis versus functioning, but that there are many different levels and layers that we need to think about if we really want to be holistic in our approach to children. And the last point, Scylla, was to remind me, when we are working in the neurodevelopmental disability community, very often we focus on challenges and problems and gaps and deficits. And it's really important for all of us also to think about the strengths, the talents, the uniqueness, and celebrate the good things, because all people with neurodevelopmental disability, including autism, bring so much joy to the world, and we really have to think how we can celebrate them and their talents too. And with that, I'm going to stop and say thank you on behalf of the team, and I hope, Scylla, we have a few minutes to engage in some question and discussion as well.
Thank you very much, Beatrice, for a very thoughtful and thorough description of the whole, of a very complex disorder. I'm wondering if we could perhaps start the discussion. Are there any questions in the chat box at the moment? I have one.
Sure.
Because, you know, often as a pediatrician seeing very young children, I'm faced by parents who are almost needing and seeking a diagnosis. And in some cases, it's a very early period of a child's life. And in fact, as you say, functional thinking makes a lot more sense at that stage. However, one is almost pressurized because often access to certain programs or sometimes social care grants depend very much on a diagnosis, and you're a little bit concerned about labeling a child so early on. What's your take on this?
Yeah, it's a great question, and it's a challenge we all have every day in clinical practice, don't we? So the first thing I'm going to say is we've realized in our context in South Africa, in most low and middle income countries, is that most families struggle to get access to a diagnostic evaluation. And there's a huge delay for many people. And so the first point we realized and we learned is we cannot wait for a diagnosis to start some intervention. And that's also very much the philosophy of the World Health Organization and this caregiver skills training program that we've developed for caregivers of children with developmental delays. So all we need is for mum, dad, granny, auntie to be worried about the child's milestones and then to give them access to knowledge, skills, etc. So in a way, that's my first simplistic answer to you, Scylla. I think if we are worried and if mums and dads are worried, we should do something. And that doing something doesn't necessarily have to be a diagnosis. And maybe through the process of doing something, the diagnosis or the formulation may emerge, because that's the second observation. Neurodevelopmental disabilities are complicated because they, in a way, unfold over time. Sometimes we can be very sure between the age of 2 and 3 that a child clearly meets criteria for autism or something else. But sometimes it becomes clearer over time. And then it's about how do we have that conversation to say, I can see these things, I can see the social communication problems, etc. There's not quite enough yet, but clearly we need to do something. So it's also helpful to explain to mums and dads when we say, and that's what I quite like for those of you who are familiar with the ADOS, when we do a toddler ADOS, we don't give a diagnosis, we don't put you in a box and say autism, yes, no. We say high risk of autism, moderate risk of autism, or low risk. So we give like a risk profile. And in a way, maybe to say, mum, dad, I see what you're worried about at this behavioral level. There's a high risk of autism. So, but I don't quite have enough to give a diagnosis, but let's get started. Let's do the things we would do when there's a diagnosis of autism. And you are right. Sometimes there is a diagnosis that opens a door to a grant or that opens a door to a school. Sadly, in our country and in many low-income countries, actually that diagnosis might close a door. If you have autism, you now need to go to a special school. And so the normal mainstream door closes for you. But in many countries, it does actually open a door. So even there, my conversation would be, diagnoses are a little bit like this, the effects and side effects of medications. Any drug has some positive and some risks and side effects. So even the diagnosis of autism might have benefits and might have disadvantages. And I would have that conversation with mum and dad and say, let's think, is it more helpful for us to use the diagnosis now to get A, B, or C? Or is it more helpful for us not to use the diagnosis now because we don't want to overlabel or diagnose or whatever inappropriately? So that's the dance I think we all need to make. So I hope that gives you some comments, even if it's not one straight answer, Scylla.
Thank you, Beatrice. I'm looking at the chat box, and Michelle Ireland has also made a comment, asked a question. Can you comment on the hesitancy of South African child and adolescent psychiatrists to make diagnoses, and what alternative processes can be used?
Right. Thanks, Michelle. I don't know if you mean specifically diagnosis of autism or of any psychiatric disorders. And I guess that might be different. So if you want to hop online, feel free to do that. And Oshi says, yes, diagnosis of autism. I'm not quite sure why people would be hesitant. I think the simple thing is, if a child meets criteria for diagnosis, and if we agree with mum and dad that it will be helpful to give the diagnosis, I think people should do that. One possible reason is maybe not all psychiatrists, including child psychiatrists, feel very confident about making diagnosis of autism, particularly when, as we go further out from the very obvious core autism. And as we get more fuzzy, as we get more towards the outer boundaries, as there's more co-occurring issues, perhaps people are unclear. And perhaps because they're not so sure, they avoid doing it, making a diagnosis rather than giving a diagnosis. So, but it's a really nice question. As I say, or you say, what else can we do? Autism can be diagnosed by many different healthcare professionals, including pediatricians. Clinical psychologists are allowed to diagnose it. And it is that balance. Again, if sometimes it's appropriate for a child psychiatrist to be hesitant about making the diagnosis, and sometimes it may not be. So it's really hard for me to give you a very straight answer. One comment I will make is there's still, for many healthcare professionals, even in our country, challenges in real high-level expertise to be able to tease out when is there enough to draw the line and say this is ADD, and when is there not enough and say there are clearly behavioral challenges, or maybe it's better explained at a neuropsychological level or something, or it's part of the intellectual profile. And sometimes, Scylla and I, when we do ADOS training, and Heather, sometimes we all scratch our heads for some children as well. I do think children on the whole in South Africa often don't have a great service when it comes to identifying the autism in the context of all the other co-occurring conditions. And we often then hear of children who are diagnosed with kind of wacky psychiatric disorders, and only that is being treated. They get diagnosed with bipolar and they get treated for bipolar, and people struggle to put together all the components. And that's why you will hear me whenever I talk about all these different things. You can have autism and some of those. And so that's where the skill comes, at knowing when and what to place the emphasis on when and what. Scylla, please join me.
Thank you. Thank you, Beatrice. There's one more question. I'm not sure how much time we've got left. Is there any data on early diagnosis and positive later mental health outcomes? I think we're running over time, but if you want to just briefly address that.
Sure. So I'm going to give two short answers. One is, if we can identify autism early and we can help people early with their communication, etc., there's clearly a reduction in the rates of other co-occurring disorders, because when we target autism interventions, it often targets many of the other neurodevelopmental disabilities too, and it often has a direct or an indirect impact also on anxiety, on mood, and so on. So yes, there is some evidence that if we target autism early, it can also help the other things. The second thing is, apart from catching the autism and working early, we also must look for all those other things, because they're not all there at the same time. So at the age of 3, you might not yet have an anxiety disorder, but maybe at the age of 7 or 8 you do. So the second thing we must also keep in mind is an assessment, a holistic assessment for autism is not a one-off event. It's an ongoing process, because today's needs of profile of this child might be very different from what their needs might be in a year, or when they're 5, or when they're 12, or when they have to transition into high school or out of high school. So we always have to say, let me catch it early. And if I can give you all one tip, if you are worried about a child, do something rather than say, let's wait and see. It's always better to act than not to act. There's my message for everyone, Scylla.
Oh, thank you very much, Beatrice. It was a really wonderful session. And I want to thank you so much for sharing your thoughts with us.
Great. Thank you all. I'm sorry I couldn't be in person with you all in the room, but at least what this might allow us to do is for people around the world to be able to join in some of our conversations.
Thank you. And thank you to our listeners. Goodbye.